Hello and welcome to 12-lead interpretation. The one tip I have for you is to constantly try to interpret every 12 lead you can get your hands on. Practice over and over, and at the end of the day, once you've seen it enough, you'll realize ECG interpretation is just pattern recognition. So without further ado, let's get into some 12 leads. I'm going to go into the 6 steps I use to interpret a 12 lead. These are going to be your rate, rhythm, axis, intervals, and waveforms, hypertrophy, and infarction. So first off, rate. For your regular rhythms, you want to use your big box method, which you can see here. You find your QRS on a big line, and you're trying to find the next QRS. If it's one big box away, it's going to be around 300. 2 boxes away, 150. 3 boxes away, it's going to be 100 beats per minute, and so on and so on. For your irregular rhythms, or if you want to get an exact rate, look at a 6-second strip and count the QRS complexes on it, and times it by 10 to obtain your rate. So this one, there's 9 QRS complexes in your AFib. Times it by 10, you got your rate of 90. Now we get into rhythm. These are the 6 steps to use when you're interpreting lead 2 to decide your rhythm. So you're going to have, is it regular or irregular? Is it wide or narrow? Fast or slow? Are there P waves? Are there P waves for every QRS? Is there any polyuria? And number 6, own it. So we know how to interpret the rhythms. Now we get into the widths. And that's the whole point of a 12 lead. So for example, a sinus bradycardia with right ventricular hypertrophy or sinus bradycardia with an inferior STEMI as an example. Now we're going back to axis for our 3rd step. Get your thumbs up and ready. First off is your normal axis. Lead 1 and AVF are both up. 2 thumbs up, your axis is good. Now your left axis deviation. 1 is positive and AVF is negative. Your thumbs have left each other. You can also look at lead 2 to see if it's a pathological or a physiological left axis deviation. Now right axis deviation. Lead 1 is negative and AVF is positive. Your thumbs are heading right towards each other. And finally, extreme axis. Both 1 and AVF are down, so 2 thumbs down. Patient is going down, 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 and having a very bad day. First one is you want to look at our P wave. Is there any atrial enlargement? Next, look at your PR interval. A short PR interval can mean a junctional rhythm or pre-excitation, such as your WPW, which we'll talk about in a future lecture. And a long PR interval can also mean a AV block. Now look at our Q waves. Are they normal, pathological, or Dagger-Michael-Myers Q waves, which is indicative of your HOCM patients? 4th step, look at our QRS complex. Is it going to be wide or is it narrow? If it is wide, look for bundle branch blocks or hemi blocks. Next, the QT interval. Look at the QTC, which is your corrected QT interval. Your QTC is going to be on a 12 lead where all your other numbers are, and just make sure that it's not over 500 milliseconds, because if it is, the patient's more likely to go into torsades. And finally, look at the T waves. They should be upright in every lead except for AVR and V1. And then look at the morphologies. Are they symmetrical? Are they asymmetrical? Are they inverted? Are they biphasic? When they're biphasic, are they up-down or are they down-up? So we're going to go over some crude drawings of atrial enlargement. Don't judge, I did terrible in art class in middle school. So our normal P waves should be upright in lead 2 and biphasic in V1. And here's obviously that drawing again. The first part of your P wave is your right atrium, and your left is going to be the later part of your P wave. So in our normal P wave, it should be upright in lead 2 and biphasic in V1. Next is our right atrial enlargement. You will have a peak wave in lead 2, and it should be greater than 2.5 millimeters. It should be peaked as well with a biphasic component to it with a P wave in V1 being over 1.5 millimeters. Next is our left atrial enlargement. This is one of the easier ones to see in my opinion. It kind of looks like a camel hump. Lead 2 has the 2 humps on it, and the P wave needs to be over 110 milliseconds. V1 has a biphasic P wave with the N negative part that is inverted, also called a terminal negative portion, needs to be about 40 milliseconds long and greater than 1 millimeter depressed. Now we talk about our biatrial enlargement. You combine all the criteria from our left and our right atrial enlargement to call something biatrial enlargement. In lead 2, it will have that camel hump morphology, but the first hump, where the right atria depolarizes, will be more peaked in comparison to the left atrial enlargement. And V1 will have an initial positive deflection of at least 1.5 millimeters. The end part of the P wave will also be greater than 1 millimeter depressed and will have a duration of over 40 milliseconds. At the end of the day, all the numbers I'm throwing at you aren't as important as the physical morphology of it, because as I said, 12-lead interpretation is mostly just patterns. Now we'll talk about our hypertrophy. We're going to have left and right ventricular hypertrophy because we have our two ventricles. So we have our Sokolov-Lyon criteria, which is the most common equation people use to determine LVH. You add the S wave in V1 to the tallest R wave height in V5 or V6 together, and if the value is over 35, you have LVH. Now this is complicated and I do not like memorizing things. So let's talk about two easy things to look at. My down and dirty way of your LVH is to look for two things. That's going to be your high voltage and your strain pattern. Now into RVH. So you need to have right axis deviation, a dominant R wave in V1, and a dominant S wave in V5 or V6, which needs to be greater than 7 millimeters. Sometimes you'll get a right bundle branch morphology and a strain pattern in your precordial leads. And the strain pattern is basically the T waves are inverted. All right, for LVH, we're going to look for high voltage. High voltage is just a fancy term for is my QRS is massive and running into each other. If I'm looking at V4, V5, V6, I can't even tell where they start and begin, along with my other ones like V1 and V2 and V3. It's just really difficult to see where they all start and begin. That's usually a telltale sign that it is LVH. And what about my strain pattern? Well, all these arrows here, you can see that strain pattern with my LVH. Now RVH. We need to look for right axis deviation. Do we have that? I look at 1 and AVF. 1 is down, put my left thumb down. AVF is up, right thumb up. They're heading right towards each other, so right axis deviation. A dominant R wave in V1 greater than 7 millimeters. Well, if I look over in V1, I can see that it is over one big box high, which is 5 millimeters there, and then you get tack on 2 right there. So yes. Now, is there a dominant S wave in V5 or V6, which is greater than 7 millimeters? V6, that definitely meets the criteria. So yes, that gets a check. That's your RVH. In this one too, you can see that in V1, V2, and V3, and a little in V4, you have this T-wave inversions. That is going to be your strain pattern. Now we get to talk about infarctions or a STEMI, which is ST elevation myocardial infarction. So for this, you need elevation in 2 contiguous leads, that is at least 1 millimeter with a reciprocal depression. In this chart, you can see the various STEMIs and the leads to look at. When I say contiguous leads, I mean you're looking for elevation in 2 and 3, and then reciprocal to them is going to be 1 in AVL. Vice versa, if I'm seeing elevation in lead 1, I need to confirm elevation in AVL, so I have 2 contiguous leads, and I look for reciprocal depression, so I look at my inferior leads at 2, 3 AVF. But unfortunately, nothing in life, and especially medicine, is simple, so unfortunately, you do have more criteria that you have to remember, especially if you're in school. And here it is for your men and your women and your ages. The big one I want you to take away from this is your posterior MI. It needs to be greater than or equal to 0.5 millimeters in ST elevation, and you're going to be looking at V7, V8, V9. You will essentially be moving your leads around to the back side underneath the left scapula. And the reason why the criteria changes there is because we have a lot more muscle, fat, adipose tissue back there, and unfortunately that does cause interference with electrodes. I do want to say that this isn't like super sensitive. I've had multiple patients with isolated posterior STEMIs who unfortunately did not have any elevation in my posterior leads, but I did have ST depression in V1 through V4. If you're a visual learner, I crudely made this graphical representation for you. The aorta has 2 offshoots. You have your right coronary artery, or your RCA, and the left main, which leads to our left anterior descending artery, or LAD. An LAD STEMI will show elevation in V1 through V4. A circumflex artery branches off of my LAD and supplies blood to the lateral side of my heart. And you're going to have elevation in 1 AVL, V5, or V6. If you have elevation in 1 in AVL, it's going to be called a high lateral STEMI. If it is V5, V6, it's going to be a low lateral STEMI. And my RCA supplies blood to the inferior or bottom part of my heart, so that's 2, 3 in AVF. And here's another visual for my coronary arteries. First, we're going to talk about my right coronary artery, or RCA. You can see that there's multiple branches off of this. Your RCA does supply for most of the patients to your SA and AV nodes, so a lot of these patients will become bradycardic. You can also have your AV blocks with this. You can also see the posterior descending artery, or PDA, that wraps around the back side of the heart. Now we get into our LAD, which is going to have these big quote unquote diagonals. You're going to have diagonal 1 and diagonal 2 that branch off of it. Then we're going to go into our circumflex, and this one obviously, like I said, wraps around or circumflexes around the heart. It branches off of my LAD and supplies the lateral side of my heart. And you can see in the very back of the heart, which is a little transparent, you can see that it does wrap around to the posterior part of my heart as well. And then we finally talk about our left main. My left main is kind of where AVR is looking at. And that is going to be the end of our 12-lead interpretation lecture. So study up, and I look forward to seeing you guys at the next lecture.